We expect the first 6 weeks to have ups and downs. I've seldom seen people really too bothered after 3 months.
Cystoscopy, is there an increased risk of infection or that it might introduce new infection?
Well, we do cystoscopies after we verify that people's urine is clear. So we don't do cystoscopy if someone is infected. And when they come, at least our institution, we give a prophylactic antibiotic that day, even if the urine is clear. So we try to minimize all the risk of introducing anything in the bladder. It's almost the same idea than taking an antibiotic with intercourse.
Mm-hmm. Okay. And are there other risks involved in fulguration aside from that?
Well, we've had a few people with bleeding afterward, especially when the fulguration is extensive. That goes away with irrigation of the bladder typically. I remember maybe 1 or 2 cases where the bleeding was such intense that we had to transfer that person. But those were people on anticoagulation usually.
Okay.
They had to resume their anticoagulation protection soon after the procedure was completed. And if you're on Plavix or heparin or whatever, that can make friable lesions bleed easily. Part of this, if it starts bleeding, you can control it. It's very diffuse and you can get blood clots quickly. So I don't remember any now in years, but we had some for a while. Maybe we're more careful in keeping people out of anticoagulation longer afterwards. But it's definitely a very, very rare risk can happen. Some people can get more infection for a while. I'm pretty sure that we do liberate some bacteria in the bladder as we unmask all these deep-seated sites. So we've prefer, although not systematically, given antibiotics prophylactically for 4 to 6 weeks after the procedure. Just a low dose, not a treatment, just to keep some antibiotics in the system, just to try to eliminate the chance of this bacteria to regroup and grow on you. But that's just because of the fulguration. After that, most people don't need that. We've had some people that had to stay on it for a while because every time we stopped, that prophylaxis, the symptoms came back and the culture came back. So we had to retreat them. And some were happy to just stay on it a little bit longer, just not to go through that again. But that's a small number of people. So
is it possible that fulguration might make it worse for some people?
That I've never observed.
Okay.
I've never observed. Everybody tends to heal. It may take some time. We've had people forming little stones sometime on the areas of fulguration. It's also extremely rare. So things, I mean, like every procedure in life, things happen. That's why I don't jump on that procedure automatically. I think it needs to be, considered and it has to be well reasoned before you go for that.
You mentioned that patients are generally put on prophylactic antibiotics after fulguration. Is everyone put on the same, or is this based on what their test results show?
No, it's based on their culture and sensitivity and which antibiotics we can use for them. So, I wish it could be the same, but by the time I see them, some have developed resistance, allergies, and I see the same. But it's just, and then some people cannot because we have so few options that they cannot, and we just do cultures regularly. Just if something comes up, and then we would treat the patient based on culture findings.
Do you only rely on culture, or do you sometimes use different testing methods, particularly for people whose cultures come back negative?
Yeah, it's a great question. Right now, the data we have is only based on culture. Many of the patients I've seen in the last several years have relied on diagnostics, microgen, and other information sequencing tools. But to be honest with you, I just don't know what to do with this information right now.
Okay.
I'm afraid that we're picking up things at such a low level that I don't know if they are clinically relevant, and I'm afraid of over-treating people. So I'm not dismissing that. In fact, it's a body of literature that is growing, which is quite fascinating, but it's not something that, because of cost and access, we've been able to do systematically. So we'll have upcoming data on the microbiome of this patient that hopefully will guide this decision better.
Okay. And alongside the antibiotics that people are put on, do you also recommend a type of pain relief?
Yeah, for the bladder, there's nothing that works very well, as you know, as far as general pain management. It's not like joint pain or back pain or migraine. The local agent that works best that we use in the U.S. are called AZO, over the counter, or Pyridium, phenazopyridine, and those are great. They turn your urine, they color your urine because they coat the surface, and they definitely take the edge off. They're very favored by our patients.
Okay.
So if we send them home, it's typically with a prescription of that to have, and some of them already have some at home, so they just take it as needed.
Okay. Is there anything that one can actively do after fulguration to help with the healing of the bladder lining?
Not for the healing of bladder lining, but there's one thing people did a lot initially until I realized what they were doing, that people are going home and were just drinking gallons and gallons of water to try to flush things out, and spend miserable days and night peeing every 5 minutes to get all this fluid out. So please don't do that. It's not going to change anything except to make you more miserable, because your poor bladder goes like through that crisis of having to contract and all the time. So that doesn't help. Drink normally. In the first few days, if your urine's a little bit cloudy or you have a few blood clots, I'm fine with increasing the fluid a little bit. But this notion I have to go home and drink, no.
Okay, that's good to know.
This is misery on the way for sure, because you just burn tissue. It's like if you burn yourself on your skin, you want to touch that area 25 times just to hurt some more? No, same for your bladder. Leave it alone. Bladder rest is probably the best when you have that. As far as what you eat or drink, well, as you know, we try to avoid caffeine and things that irritates the bladder, alcohol. For some people, everybody have their own thing. Their bladder worse, stay away from that. Same for what you eat. If tomatoes give you, a terrible day with your bladder, then don't eat tomatoes after the fulguration.
Right.
Common sense. You know yourself, and whether it's your bladder or your bowels, you know what things you tolerate, you don't tolerate. So.
Okay. What does recovery look like for most people? Is it linear, or do their symptoms tend to come and go? And how long does it usually take?
Yeah, I think we expect the first 6 weeks to have ups and downs, and probably goes even into 3 months or more. I've seldom seen people really too bothered after 3 months. And again, we will get more of that data to you scientifically after we review that. As I said, I usually try to protect people for the first week after the procedure. Make sure that they don't have any obligations to do things or travel or work. And if they're fine, they can go back, obviously, the next day. It's not a problem, but I would hate to be stuck in a, traffic jam and not being able to, empty my bladder if I have to, just things happen wherever. So, the work can wait a few days, and you need to find help at home if you need for that. And after that, it's usually, it will heal for sure. It's a question of how long will it take. And the depths of these infections in the tissues is not something that we can appreciate from the surface. You see a tree, you don't know how deep the roots are, right? It's the same. There is infection on the surface, you just don't know how deep rooted those infections are. So I'm sure that for some people, maybe they have a different, innervation as a result of that. That may be more sensitive nerves. I can't tell you, Melissa, because we don't have access to that type of knowledge. We're only seeing the tip of the iceberg. We don't see what's below. So I try to prepare my patients for the worst, because I think that's what I should do. And oftentimes we're happily surprised that things go quite well. But yeah, I've seen people that, at 6 weeks were in my office saying, when will this go away?
Yeah.
And it does. So, but I have no predictors. I can't tell you if it'd be you next time or someone else.
And then once they do feel better, how long is that benefit likely to last? For some people, is that forever?
That's forever. Yeah, that's what we talk about. That's the success, improvement and failure that we just discussed a minute ago. So once it's healed, it's healed. I mean, think about yourself. Have you ever burned yourself? It's from a scab. The scab comes off, and then the tissue, returns to normal. It takes weeks because, with the outside dry air, the wound heals quickly. The bladder has been wet, and with different level of acidity based on the urine pH, that chemistry down there is a mystery to me, and I don't have ways to control it.
Okay. We had some questions from international patients. Do you provide fulguration for people traveling from overseas?
Of course, yeah. I mean, we're at a big university, one of the top 10 in the country, and people flying to left field or Dallas Fort Worth. And I've had people coming from abroad.
Mhm.
The problem is for them more insurance coverage than anything else. And I don't deal with that. It goes directly to our billing department to help them out with that. And we
Mhm.
try to, once we know they're coming, we try to increase the logistics around, how long they should stay. And most of them stay 7-10 days before they
Okay.
fly back, just so that if anything happens, like you just mentioned, I'm around. And
Mhm.
sometimes they have people at home that can help them, infectious disease specialists, urologists, gynecologists, other people that can help them out.
Mhm.
But I prefer when they're going to be far away to keep them here for a few days. Some of them need more testing. Some of them need bladder X-rays, MRIs, and we have to make sure everything is scheduled before they come, so they don't
Right.
lose it. But yeah, absolutely. We nowadays with telehealth, people
Mhm.
call anywhere. So
Yeah. Can
this
you
happens in my practice every month. I would say.
okay. Can you share any insight into the costs involved in this type of procedure?
I wish I could. I really don't know because for each one of them, it's based on their insurance coverage. So,
So for some people, insurance does cover this.
no, it's always covered by insurance. Fulguration is covered by insurance in the
Okay.
US. There's absolutely no out-of-pocket cost. For
Okay.
people that come from outside with different insurance coverage, the university has tried to make some, deals with their insurance. I really don't know. I don't. I have
Yeah.
so much work on my hands taking care of my patient. The
It's
rest,
difficult.
yeah, I don't deal with that. But we've looked at costs of this procedure. We've published on that as well.
Mhm.
We continue to get data on that. In fact, there's another publication coming up on costs. So we're
Okay.
looking at the cost benefit of having a fulguration, compared to continuing on with antibiotics and so on. Not counting the human dimension of feeling better and doing better and not having to deal with that anymore. Just the pure cost of
Right.
kind of arresting the process by taking care of it, is obviously an important, consideration. So we worked on a theoretical publication a few years ago looking at how we could itemize the cost, and then we went into looking at real life data to see how that uh, theoretical calculation fit everyday life.
Mhm.
So those things will come out.